Hey guys, this is Dr. Aishwarya from Department of Oral and Maxillofacial Surgery, here to give a brief topic on Odontogenic Cysts and Tumors. So, going on to the introduction, a cyst is an epithelium-lined sac containing fluid or semi-fluid material. The epithelial cell first proliferate and later undergo degeneration and liquefaction. Grows by expansion, causing displacement of the adjacent. Odontogenic cyst originates from the residues of the tooth-forming organ, derived from three organs: the epithelial rest of seres, odontogenic keratocyst, developmental lateral periodontal and gingival cyst. Reduced enamel epithelium includes the dentigerous, eruption, and the paradental cyst, and the rest of malaise is the residual cyst. The radicular cyst, subdivided into apical, lateral, or residual. Causes for the radicular cyst is develops from the pre-existing periapical granules related to the apex of the non-vital tooth. Clinical features: high incidence in anterior maxillary teeth, usually symptomless. When enlarged, causes expansion of the alveolar arch and may discharge through the sinus. The rate of expansion is 5 mm per year. Histopathology: lined by a non-keratinized stratified squamous epithelium, chronically inflamed fibrous tissue capsule. Newly formed cysts have irregular epithelial lining with a variable thickness. Becomes regular and even in thickness over a period of time. The connective tissue capsule becomes more fibrous and less vascular and with a less inflammatory cell. Metaplasia of the epithelial lining may give rise to a mucus cell and rarely ciliated respiratory epithelium. In some cases, the lining contains highly eosinophilic bodies and rustant bodies. Common cholesterol crystal deposits which forms clefts. Cholesterol crystals results from the hemorrhage and from the RBCs. Radiographic features include a round radiolucency at the root apex, well defined, surrounded by radio-opaque margin. 40% of the apical radiolucencies are cystic. The content is a hypertonic fluid containing a breakdown product of epithelial, inflammatory, and connective tissue elements. Serum protein of about 5 to 11 gram per dl. IgS higher than the serum, and water, electrolyte, and cholesterol crystals. Moving on to the residual cyst, it is a radicular cyst that is retained after the extraction of the related tooth, may continue growth, causing a significant bone resorption. Dentigerous cyst, enclosed part or all of the crown of the unerupted tooth, develops from a proliferation of the residued enamel epithelium. Eruption cyst arises in an extraalveolar location. Radiographic examination is a well-defined unilocular radial lucent related to a crown associated with impacted or delayed eruption, most commonly seen in the lower 8 and upper canine region. The clinical features includes more common in male dominance and twice as common in mandible. Usually asymptomatic, a larger cyst tends to expand on the outer plate. Histopathology: lining is a thin, irregular, 2 to 5 cells thick, non-keratinized stratified squamous or cuboidal, fibrous CT capsule, connective tissue capsule free from inflammatory cell infiltration. Occasional cholesterol cleft is seen. Organogenic keratocyst is uncommon. Second and third or fifth decade, more common in male, asymptomatic. Multiple cysts are associated with an evert basal cell carcinoma syndrome. Radiographic features: third molar and ramus of the mandible are most commonly seen, and well-defined radiolucency is seen, can display and resorb the teeth. It's normally uni or multilocular. Histopathology is a wall is thin, regular, 5 to 10 cell thick stratified squamous epithelium, characteristic folded wall. Basal cell layer is well defined, contains columnar or cuboidal cells. Sudden transition between the stratum spinosum and the surface cell. Histopathology: a thin fibrous capsule free from inflammatory cells, high recurrence due to rupture. Cyst contains keratinous debris with cheesy material, protein level of about 4 grams per dl. Garland Syndrome. Garland Syndrome is an autosomal dominant uncommon manifestation: skin, multiple navate basal cell carcinoma, oral, multiple odontogenic keratocysts, and skeletal rib vertebral anomalies, polydactyl, cleft lip and palate, CNS calcified flux cerebrae brain tumor. Gingival cysts, common in neonates, also known as the bone nodules or absent pearls, disappear by third month of the age, arises from the remnants of dental lamina. Developmental lateral periodontal cyst is the most uncommon, and canine and premolar regions of the mandible are derived from either reduced enamel epithelium or rest of the dental lamina, occasionally multilocar. Radiographically, a well-defined radiolucency, large cysts can displace teeth and causes expansion, histologically lined by a non-keratinized squamous or cuboidal epithelium. Paradental cyst arises along the side and of underdepth third molar, involved with pericoronitis. Radiographically, a well-defined radiolucency related to the neck of the tooth, inflammatory origin stimulating the proliferation of the reduced enamel epithelium. Glandular Orangogenic cyst, it is very rare, occur in the anterior part of the mandible, a slow-growing and a planeless tumor or a cyst. Histology, lined by a varying thickness of epithelium, potential aggressive and locally invasive with a tendency to reoccur. Moving on to the Orentogenic tumor, odentomes, it's a non-neoplastic developmental anomaly or malformation that includes enamel and dentin. Types, invaginated, evaginated, enamel pearl, double tooth, complex odentum, and compound odentum. Invaginated odontom is invagination of the enamel organ into the dental papilla early into odontogenesis. Permanent maxillary lateral incisors. Three main types confined to the crown, extend into the root, extends to the root apex. Histologically, enamel and dentin lining the cavity are often definitive and poorly mineralized. The cavity is occupied with food debris and bacteria. Evaginated odontom, uncommon, extra cusp-like tubercles are seen, easily fractured and exposing the bulb. A complex odontom is a disorderly arranged dental tissues, limited growth potential, second and third decade in the molar region of the mandible. It is a painless, slow-growing tumor. Radiographic examination is a well-defined radiolucent lesion, proceeds to a radio-opaque. When mature, it is surrounded by a translucent zone. Histopathologically, developing lesion containing varying amount of soft tissue and shows features of stages of odontogenesis. Compound odontum consists of a numerous small denticles in the first and second decade of life and in the anterior of the maxilla, less growth potential than the complex type. Radiographic examination, mixed radio-opaque or translucent bodies are seen. And amyloblastoma, a rare, a benign, locally invasive, derived from odontogenic epithelium. More common in Africans, two variants, unicystic and peripheral. 80% occur in the mandible. Radiographic examinations, a multiloculator radiolucency resorption of the roots around it may become associated with the unerupted third molars. Histopathologically, two patterns, follicular and plexiform types. Follicular is the epithelium arranged into discrete follicles resembling the tooth germ, and plexiform is the epithelium is arranged in the tangled network and irregular masses. The amyloblastoma-like cells express amylogen, however, the enamel and dentin are not formed. Behavior, locally invasive, infiltrate cancellous bone without bone destruction initially, high recurrence rates. Unicystic amyloblastoma occurs in younger age than the other variants, mainly in mandibular third molar region. Histologically, ameloblastoma lining with a reversed polarity nuclei. Radiographically, unilocular radiolucency, usually associated with the underruptured tooth, distinguishable from a dentigerous cyst on by histopathological examination. Squamous odontogenic tumor is a rare, radiographically well circumscribed and radiolucency, sclerotic border associated with the root of the teeth, histologically irregularly shaped island of well differentiated squamous epithelium in the stroma of mature fibrous tissue derived from the epithelium of cell of malaise. Calcifying epithelial odontogenic tumor is a rare benign tumor. Wide age groups seen most commonly in mandible and maxilla. Mostly seen in molar and premolar region. 50% associated with the unerupted tooth. Radiographic features includes irregular radiolucent area, may or may not be clearly demarcated, contains radio-opaque bodies due to calcification, less aggressive than amyloblastoma. Histopathologically, sheets and strands of polyhedral epithelial cells, abundant eosinophilic cytoplasm, a prominent intercellular bridges, and a nuclear pleomorphism is seen. Adenomatous Orangogenic tumor present usually in second or third decade of life, majority in anterior maxilla and a slow growing swelling. Radiographically, it's a well-defined radial lucency, faint opacity due to calcification, may simulate a dentigerous cyst, often associated with an unerupted tooth. Histopathologically, when encapsulated lesion may be partly or wholly cystic, central spaces contain eosinophilic material, a small foci of calcification. Ameloblastic fibroma is a rare benign tumor, neoplasm of epithelial and mesenchymal element, which is well circumscribed. Histopathologically, proliferating strands of odontogenic epithelium in highly circular fibroblastic tissue with a peripheral layer of columnar cells, appearance similar to ameloblastoma. Calcifying cystic odontogenic tumor is a grossly cystic, mostly intraosseous, radiographically well-defined uni or multilocular radiolucency with radio-open areas. Histopathologically, a basal layer of ameloblast-like cells, malaise, and swollen keratinized epithelial cells are seen, are the ghost cells. And odontogenic fibroma derived from the mesenchymal dental tissue, two types. Central type uncommon, well demarcated, cementum-like and dentin-like foci. Peripheral type is a fibrous epiphyllous or fibrous tissue with cementum or dentinoid materials are seen. Odontogenic myxoma, a locally invasive, more common than odontogenic fibroma. Radiologically, multilocular, a soap bubble appearance is seen, a well-defined, and root shows absorption. Histopathologically, it's a non-encapsulated infiltrative growth pattern, stellate cells with anastomosing processes. Symmetroblastoma, most patients under 35 years of age, usually molars and premolar areas of mandible, attached to the root of the bone vital and slowly enlarging, sometimes causing pain. Radiographically, a well-demarcated molded radio-opaque radiolucent margin and root resorption is seen. Histopathologically, cementum-like tissue surrounded by tissues of uncalcified matrix.